My name is Elena Critselis. I'm an assistant professor in epidemiology and public health. And today I'll be touching on a topic that's very close to my heart, which is really the epidemiological tools for bridging the divide in bench-to-bedside research. And within this context, what I would like to do is to cover a couple of topics today. One of them is to basically touch upon how we develop different clinical indices and particularly clinical omics-based biomarkers for the diagnosis and prognosis of disease. And from there on to touch upon proposed steps and epidemiological tools for maximizing biomarker research investment, and to see how this is all translated into clinical practice, to move on to a case study of actually one of our more recent works conducted through the Biomedical Research Foundation of the Academy of Athens in Greece, along with another 10 participants from across Europe within the context of a large European project, to see how we developed a urinary proteomics biomarker for the diagnosis and prognosis of chronic kidney disease in type 2 diabetes mellitus patients. Now, all of this is basically arising, to be honest, from my personal love for epidemiology, which, to be honest, I came around to recognize quite delayed. Truth be told, as some of our students who are attending today's session may also feel, as a first-year student, I do remember attending the first bioinformatics and biostatistics and research epidemiology, research methodology courses, and I just couldn't make sense of how this all relates to the healthcare sciences that I was interested in at the time and continue to be until today. But the truth is, through the persistence of my professors at the time, through the exposures that I had the wonderful pleasure to join in, I came to realize that in truth, research methodology and epidemiology is the backbone of clinical medicine, because it's what really pushes us forward, propagates research, and in essence propagates clinical practice. So today, I want to relay that realization to you and how I've experienced it over the most recent years through the development of what I feel is one of the most important tools that we can use and develop, and that is that of clinical indices, scales, scores, or biomarkers, as you wish to call them, all of those tools that we use in our clinical diagnosis, in our assessment of prognosis of patients, and as well as in our choice making, if you like, of which treatment options are most or probably most effective for our patients. So I will be focusing on biomarkers today, but please keep in mind that this is a general principle that may relate to all clinical indices, scales, and scores. And just to touch upon what these really are, as you may recall from examples, as you can see on your left-hand side, which are the Med Diet score. These can be scales and scores used to grade the risk and the categorization of patients. More clinical scales that you may be aware of are those such as you may see in the center of the slide, the Glasgow Coma Scale, as well as the APGAR score, as used most often in pediatrics. But most recently, we've seen during recent decades that these have developed to focus more on single or comprehensive biomarkers, if you like, which may begin and be identified such as single inflammation markers, such as CRP, onto more complex and, if you like, state-of-the-art biomarker panels that have been most recently developed based on new state-of-the-art platforms. So clinical omics is really the large-scale study of proteins, also known as proteomics, metabolites, also known as metabolomics, RNA transcripts, known as transcriptomics, and or DNA genomics. All of these come together either individually or in combination to identify and quantify large numbers of proteins, metabolites, or genes in a functional context so as to better understand the molecular basis of diseases. And the ultimate aim of these is to develop a single or a combination of biomarkers associated with various diseases, and most often those which pertain to either disease onset, progression, or therapeutic response. And we'll see these analytically in a bit. Now, traditionally, when these were first developed by Dr. Wilkins, he was one of the first pioneers in this field, especially in proteomics. Traditionally, we sought to focus on identifying a single biomarker of a disease, that is, a single marker of disease. But more recently, we've come to recognize, first of all, that these diseases are a lot more complex than we could ever imagine, especially chronic non-communicable diseases, which have an array of risk factors related to them and contributing factors in their etiology. And so we've focused more and more on developing comprehensive arrays of individually related biomarkers, which are also known as either biomarker panels, signatures, or classifier scores. Now, these have come about since most recently, state-of-the-art platforms allow us to have these kind of high throughput biomarker panel score identification, but above all, because we recognize that although these are more complex, their comprehensiveness allows them to be more robust than single biomarkers, and therefore they're not as easily influenced, and in a way reducing their accuracy by other external genetic, anthropometric, lifestyle, or other environmental factors. So what I would like to focus on today, just as a prime example, but in essence, as was predefined, this presentation does really relate to all of the omics sets, and in general, all of the scales and scores that can be developed, as you'll see as we come around through this presentation. What I would like to specifically focus on today as an example, as a case in point, is that of proteomics. And proteomics is really the focus of protein properties of interest that may be related to disease. Now, these may be related to either physical characteristics, chemical characteristics, or even solubility and other factors that are related to proteins. And in this way, we see the changes in the proteins and the peptides, both at the cellular level, but also at the tissue level, as well as their interactions along biochemical pathways. We use several strategies for discovering peptide biomarkers, and I don't want to get too much into the details of this, more so because I myself am not a biochemist, as you may know, but above all because I don't think that's within the scope of today's presentation. What I just would like for you to keep in mind is that we have many different techniques that we can use, especially in proteomics, as well as in other omics platforms, for analyzing these characteristics. And therefore, we have a wide array of what we can use from there on to process our works. This being said, our basic generalized workflow is quite common for all omics platforms, and actually for all biomarker and classifier platforms. These basically begin with a phenotype or a disease or a condition that we are interested in. Usually our preliminary work is to see how we can see the different disease states or the disease side effects in model systems, usually animal models. And based on mass spectrometry-based discovery, usually, which is one of the most common approaches used, at least specifically in proteomics, we try to identify what we call differentially expressed proteins and peptides between those with disease and those with controls. So we try to see which proteins are different between these two groups. We do this by carrying out appropriate and stringent statistics. And in sum, once we find which peptides or proteins are different between these two groups, and therefore are suspected to characterize those with disease, or specific to those with disease, we proceed with validating these in a large patient cohort using other more robust, if you like, epidemiological approaches. And once we validated those in the group of patients in our patient cohorts, then we proceed to actually identify in total the biomarker or biomarker signature or panel, as you may wish to call it, which is related to disease biology. And that in turn can be applied through several methods, which we will analyze today, into clinical and above all public health practice. So this is a generalized workflow specifically for proteomics, but it translates into other omics platforms and in general in biomarker development. And for proteomics, we have different, as well with other omics platforms, we have different sources of samples that we can use to conduct these activities. The most commonly used ones are those of urinary and tissue samples. Urinary are most often preferred because they're non-invasive in their collection. Tissue samples, by definition, usually require more invasive techniques, so we usually use them for the validation of initial findings. But in every event, the flow is quite common and quite standard. We start with our sample analysis based on any of the platforms, and I would just like to generalize this to make it as simple and straightforward as possible. No matter which of the state-of-the-art platforms we choose to use, the analysis is one and the same, and its targeted approach is what we just discussed, which is to identify those peptides or proteins which are differentially expressed between patients and controls. That is, those with disease and those without, to just be more accurate in the expression. We verify these findings through more, if you like, robust and standard approaches and statistical analyses. And based on these findings, we construct our comprehensive biomarker panel scores, which we then proceed to validate in an independent study population. And then, if all is well, we choose to validate these based on a targeted context of use. That's what where we want to use it in clinical practice so that we can immediately translate it into clinical and, by extent, public health practice. So in total, more advanced proteomics technologies can be applied, more advanced platforms, but what I would like for us to keep today is the basic concept that no matter which of the more advanced proteomics technologies we choose to use, whether these are gel-based proteomics or gel-free proteomics, we always start with this essential need for patient samples, proceed with protein extraction and protein separation, and ultimately through these platforms we choose to identify the biomarker assay pending the context of use, the intended context of use. So we can have a biomarker which will be used in diagnosis of disease. We can use a biomarker which will be used to predict disease outcome, that is what we call a prognostic biomarker, or to also predict treatment response. There are many other categories for this. Actually, there are more than 7 types of biomarkers that have been commonly identified in the literature, including those which have to do with risk of disease, monitoring of patients, pharmacodynamic or response biomarkers, and safety biomarkers. But for the purposes of today's presentation, I would like to focus on 3 biomarkers, which I feel at least are those which are most commonly identified and used in clinical and public health practice. And these are diagnostic biomarkers, prognostic biomarkers, and predictive biomarkers. Now, diagnostic biomarkers are those which identify patients with a condition or disease of interest, irrespective of the patient outcome. So it's really what you want to have on the first visit of a patient to identify whether they either have or are likely to have a specific disease. In contrast, the prognostic biomarker identifies those patients with differing risks or likelihoods of a specific clinical event or outcome. Usually these are adverse outcomes such as disease recurrence, progression, or death. And these outcomes, their likelihood at least, is assessed based on the prognostic biomarker regardless of the treatment given. So prognostic biomarkers are, in a sense, there to predict what the risk of an adverse outcome is in a group of patients or a specific patient that we are targeting, and are not used to actually guide the choice of a particular treatment. They're more so to predict whether you're risking to have an adverse outcome occur regardless of that treatment. Finally, we have predictive biomarkers, which predict which patients will experience either favorable or unfavorable treatment effects from a specific therapeutic intervention. And here we have these biomarkers coming to serve, once again, following diagnosis during the workup of which particular treatment strategy we should be choosing, so as to kind of, if you like, have a more approximate estimation of which patients will respond more favorably and therefore should be given a specific treatment strategy as compared to others. So therefore, predictive biomarkers are used commonly to guide the choice of treatment. Now, there are different appropriate research designs per biomarker type. As most of you may recall, we have the standard hierarchy of research methodology over here, beginning from the bottom to the top. We have the least robust to the most robust at the top of study designs, including both analytic observational studies such as cross-sectional studies, case control studies, and cohort studies, as well as interventional studies with a keen focus on randomized controlled trials, RCTs. Now, diagnostic biomarkers, as you can see on the right-hand side of today's slide, are most usually and most appropriately investigated through cross-sectional and case control studies. We'll see the details in a bit, how this is done and performed. Prognostic biomarkers, which are there to see what the likelihood of an adverse outcome is, are usually identified and further validated in case control and cohort studies. And finally, predictive biomarkers, which are used to guide treatment, are most often and most appropriately investigated by RCTs, by randomized controlled trials. Now, despite all the efforts done in biomarker development, the truth be told, we've got this wealth of evidence being accumulated over the last few decades. If you think about it, actually, these state-of-the-art omics platforms, not only in proteomics, but in general, and particularly in genomics too, have been developing over the course of the past 20 to 30 years. And there's been a volume of research dedicated to the development of biomarkers from either single omics platforms or in combination between them. And as you can see on the bottom left-hand side of this slide, while there's a great proportion of efforts dedicated to what we call the discovery of biomarkers, the identification of new biomarkers, that is, only 6% of those originally investigated are actually dedicated to the verification of biomarkers in clinical practice. So we can see that there's a huge volume of efforts being done in biomarker research, but unfortunately there seems to be some kind of barrier there that we can't actually translate this easily into clinical and public health practice. And there are further gaps that have been identified, what we call innovation gaps in biomarker research and development. And as you can see on the right hand of this slide, is that most of the gaps are either focused on what was just mentioned previously, that is that there's a strong focus on biomarker discovery, not so much in its verification for clinical use. So it's kind of sitting there on the research bench and not being translated into the hospital setting or the public health setting. But added to that is likely what is even more important is that most of these investigations, unfortunately, at least until to date, are insufficient in demonstrating the added value of these new clinical biomarkers in clinical practice, and therefore they're not translated into a commercially viable diagnostic biomarker test that can be then used. So what are these challenges in biomarker implementation? There are several that have been identified. I'm just going to highlight a couple today, and from there on we'll see how we can overcome them and translate this in general to biomarker research, whether it's based on omics platforms or not. So the first key barrier is that which follows the initial identification and verification, which is pretty much our starting point over here. If you see the first mountain that is reached after a lot of effort. Following the bringing the evidence forward to a panel of experts and evaluation of appropriate biobank samples, our first big challenge, if you like, is that most often samples are not available from clinical use, patient samples that is, for biomarker verification. Moreover, there's a second barrier, if you like, which comes along from the evaluation and appropriate interventional trials for assessing selected endpoints to enable timely implementation. That is, a lot of these times, even though we have the patient samples, they're not assessed afterwards in a robust study design. And finally, to reach the implementation in clinical practice, while this may seem like the end gate, in truth, there's one step still further. And that is that if using this biomarker is not proven to be cost effective, it will never be adopted. That's the reality of our world. So there are several barriers here. And I would like to just focus on some of the key methodological impediments in maximizing the translational potential of biomarker research. And these are actually three, just three, but the main three, if you like, at least to my personal, according to my personal point of view, as well as my co-authors. So the first is that the intended context of use of biomarkers frequently remains unspecified and inadequately addressed by the study design employed. That is, very often biomarkers are not assessed or developed even or discovered with that clinical perspective in mind. I mean, where are you going to use this? Where do you need it in the differential diagnosis? Where do you need it to guide treatment strategies? What's that, if you like, that fork in the woods that you need to use that biomarker to guide you further on what you're going to do? The second main impediment is that the added value of biomarkers to current clinical standards is rarely assessed. So most investigations address diagnostic performance, that is what we call discrimination in the literature, so how much they can separate between patients and controls, but they don't focus on the clinical utility. And the truth is that the demonstration of the added value of the biomarker is needed, since improved discrimination does not necessarily translate into clinical utility. That is, just because you have something that has a high sensitivity and specificity, if it's not better than what you are, that which you already have in clinical practice, it's not much use. Now, positive and negative predictive values can offer insights about potential biomarker applicability in clinical settings, but of course, these fluctuate, and sometimes very rapidly, as we have seen also as a keen example from the past year through the COVID-19 pandemic, according to the population prevalence and incidence rates of disease. So they're not always such a shining light to guide us along our research paths. And finally, randomized trials for evaluating biomarker added value and clinical utility still remain scarce. That's the truth and reality of it. Above all, because they're a huge investment, if you like, both from human resources and costs, but also because the translational potential of randomized trials can often be limited according to different countries' healthcare settings and healthcare systems. And this is something that we will seek to address later on today. Finally, biomarker adoption at the public health level requires evidence in support of their cost effectiveness. And as was told, if it's not cost effective, truth is that it is least likely that it would actually be adopted in practice. So how do we overcome these barriers? Along with some esteemed colleagues, we proposed 6 simple steps and epidemiological tools that could be applied, readily applied, for maximizing biomarker research investment. And this is where really we feel that epidemiology comes to serve clinical research and basic research to bridge the divide so that these two fields can be facilitated in their communications, and basic research findings can be translated more directly into clinical practice, and by extent from there on into public health practice. So 6 proposed steps in epidemiological tools to be used. The first is to identify a clear clinical need or current gap in clinical practice. The second is to conduct biomarker discovery, what we also call the test set, based on appropriate study design and statistical analyses. The third is to validate these findings in independent cohorts and with appropriate study power. And the fourth is to assess the quality of independent investigations finding based on evidence level grading, because ultimately what we really want to aim at is an evidence based approach targeting towards personalized medicine. Moreover, the fifth step is to conduct cost-effectiveness analyses of potential biomarker implementation, and finally, to design, implement, and evaluate related public health interventions based on an evidence-based framework. So 6 steps and epidemiological tools that we can readily apply. And just to see them in a little more detail, so for step 1, which is to identify a clear clinical need or current gap in clinical practice, there are several tools and approaches that we can use. The first, so as to identify the clinical needs and current gaps, we can use observational studies, systematic reviews and meta-analytic findings, or even expert opinions or emerging case series, as was documented also through the COVID-19 pandemic in the initial phase and was used to a great extent. To quantify these gaps and needs, we can use epidemiological measures of frequency and burden of disease, including incidence and prevalence rates, morbidity, mortality, and case fatality rates, as well as indicators of the quality of life of patients, including QALYs and DALYs lost. And moreover, we can evaluate the health services use and costs based on annual healthcare costs incurred from a healthcare provider perspective. Finally, we can estimate the potential and costs of prevention based on projected time trends and disease burden and healthcare associated costs. So we can use time trends and time series analyses to our benefit to project what lays ahead if we can predict the future that is. Now, how do we express these? I like to call this the big bad wolf paradigm. So basically what we want to express is how big is the problem, and we can express this by using disease frequencies or anticipated total and specific burdens of disease. How bad is the problem? Well, here we want to pull upon what the impact is on patients' quality of life, either expressed as QALYs or DALYs, or if you like, in monetary terms, such as healthcare associated costs. And finally, how dangerous is the problem? So what are the mortality and case fatality rates? What is the projected widespread impact of this disease if it remains unaddressed on the population health? The second step for proceeding further is that for conducting biomarker discovery based on appropriate study design and statistical analysis. Now, we briefly discussed appropriate study design, but this should be based on the research hypothesis and the type of biomarker under assessment. I can't highlight this enough. These things go hand in hand. If you know that you want to do a diagnostic biomarker, you've got to match it up with either a cross-sectional or a case control study. In analogy, if you want to investigate a predictive biomarker, that which will predict therapeutic response, it's a one-way street there, and your choice is basically a randomized clinical trial. Now, there are several characteristics of study design and statistical analysis that we can take into consideration and use all these research methodological tools to our benefit. And these include the selection of comparison groups based on the clinical context of use, so that we know where we're targeting, like which patient groups we're trying to separate between with our biomarker as it's applied, appropriate comparisons and statistical analyses, and also to employ patient-oriented outcomes. These are always preferred because always, not only in the evidence level grading, but also at the practical level, we want our biomarkers, when they are applied in clinical practice, to really change patients' quality of life, not just our medical charts and our measures of lab tests. That being said, many times due to time constraints and just to conduct what we call proof of concept studies, just as an initial pilot, if you like, we opt to use surrogate instead of hard endpoints, but this is a debate and question of whether these should be more often applied. So as we said, appropriate study design based on the type of biomarker that we want, diagnostic biomarkers with cross-sectional and case control studies, prognostic biomarkers with cohort studies, and predictive biomarkers with randomized trials. Now, just as a brief overview of what these all are, just so that we come together and we're speaking the same epidemiological language, if you like, especially for younger attendees in the audience. So cross-sectional studies, which are on the basis of our observational studies, are excellent for discovery and test sets of diagnostic biomarkers. They're basically what we call snapshot studies. They're a single time frame, and all factors are evaluated at the same time, including the presence or the absence of the biomarker, the presence or the absence of the disease that we're interested in, as well as confounding factors. That being said, they have several limitations, although they're easy to implement and they're not that costly, to be quite frank, in relation to other study designs. And they're excellent for assessing multiple biomarkers or various disease stages at the same time. So it's a good bang for your buck, if you like. They do have certain limitations. They're unsuitable for assessing rare diseases, for one. They're susceptible to confounding effects or treatment effects, since there aren't any washout periods being controlled for. And they always necessitate further validation in other cohorts or longitudinal studies, since their findings are not confirmed from a standpoint of a temporal association, that is a chronological sequence of events. Now, case control studies, going one step up, are appropriate for discovery or test sets of diagnostic or prognostic biomarkers. They can also be used as validation sets for diagnostic biomarkers. That is, once you've initially identified a diagnostic biomarker, say in a cross-sectional study, you can take it a step up on the hierarchy of research study design and validate it in a case control study. The study population is selected based on the presence or absence of disease, and controls here, in contrast to other epidemiological studies, are most appropriately selected based on the clinical context of use. That is, very often healthy controls are not the prime choice here, but rather which is the second patient group that you would be trying to decipher between in a diagnostic procedure, etc. The evaluation method used in case control studies is that of comparing patient groups based on pre-diagnostic biomarker positivity, and therefore they require the retrospective assessment of biomarkers. And this in turn, since we do need these pre-diagnostic samples, we most often turn, and this is really the gold mine of biobanks, to biobank samples, since these are collected in the past and we can see subsequently in the future, especially when this is done amongst otherwise healthy persons, their development of certain diseases. Now, several pros and cons over here. Case control studies are excellent for assessing rare diseases, and you can assess multiple biomarkers for constructing a biomarker panel, a more comprehensive biomarker panel, that is. But they do rely on previously collected samples, and therefore they are the approaches which require the use of biobanks for proceeding further. This being said, even if that is used, many times their generalizability is quite limited based on the criteria used to select the patient and control groups of the particular studies. And this brings us to the next step, which is really what we most often target to use in biomarker discovery and validation, and that is cohort studies, longitudinal studies. They're excellent for testing and validating, especially prognostic biomarkers. We usually use two different types of cohorts to either discover or validate biomarkers. One is what we call the healthy or inception cohort, that is where we have biomarker sampling prior to or at an early onset of disease and follow these people up for disease occurrence, or in a patient cohort, that is we acquire a cohort of patients who have been entering the study either at diagnosis or at the early disease stages and follow them up for disease outcomes. They may entail either prospective or retrospective assessment. So once again, we can call upon the use of biobank samples if we like, and we want to conduct a retrospective assessment, but prospective sample collection is also applicable here and most often selected. Cohort studies have several pros Amongst them are that they do not rely exclusively on previously collected samples, so these can be prospectively collected. They allow for the assessment of multiple disease and patient outcomes, and investigators can assess several confounding effects. Even so, they require extensive time, financial and human resources, and patients are often lost to follow-up, and therefore they also require lengthy latency periods to be addressed and considered when designing the studies. So there are large investments to be conducted here. Finally, we have randomized clinical trials, and these are primarily used for the test and validation of predictive biomarkers to predict therapeutic response. But above all, what I would like to highlight here is that randomized clinical trials are most appropriate for validating all biomarkers, regardless of their type, in clinical practice for public health implementation. Now, our next step in these procedures, step 3, is to validate the discovery set findings in independent cohorts with appropriate study power. So this can be done either in prospective cohorts or randomized trials. And there are several characteristics of appropriate study design and statistical analysis that we ought to take into consideration, including, of course, the appropriate study design, the selection of comparison groups based on the clinical context of use, sufficient sample size and power, because here we're no longer in the scope of a proof of concept, but rather in the scope of validating our findings, as well as selecting hard endpoints and patient-oriented outcomes to investigate the impact of our biomarker on patient outcomes, and also, above all, adjusting for confounding or other mediating effects. Now, our next step is always to assess the quality of independent investigations findings based on evidence level grading. And we have different types of evidence level gradings that can be used. Two of these are the Oxford evidence-based medicine levels of evidence, or the grading of recommendations, assessment, development, and evaluation. What I would like to focus on is that no matter which one is used, what we ought to do and what we strive to do is to actually grade the evidence that has been accumulated from several independent studies. Now, there are different sets of grading to be acquired. I'll just use the Oxford EBM, since that's what we use most often in proteomics, which has 4 levels of grading going from A to D, where A is the highest level of grading. And without going into too much detail, I would just like to focus that depending on the type of biomarker that we're examining, the evidence level grading criteria are changing according to the study design required. So say in a diagnostic biomarker, case control studies are quite low, if you like, and automatically categorized one of the lowest levels of level 4. In contrast, in prognostic biomarkers, case control and cross-sectional studies are not even taken into account in the grades of recommendation, but rather only cohort studies, and particularly inception cohort studies, are considered. That being said, not all cohort studies are the same, so the cohort studies to be considered do have to fulfill the highest methodological criteria regarding the selection of comparison groups, measures of exposure, and consideration of confounding effects. And finally, for predictive biomarkers, here we see that the grading of evidence, according to the Oxford EBM, allows for the consideration of only randomized trials and cohort studies and none of the other study designs. So we can really see that in total, the type of research design comes to tie in with what we will then use to assess the grading of evidence. Proceeding into our last 2 steps for maximizing research investment for biomarker development. In step 5, we have cost effectiveness analyses of potential biomarker implementation. Here we have to basically prove that our biomarkers are cost effective so that they can be potentially considered for further use at the public health level. Now, cost effectiveness analysis can account for numerous factors. What we usually try to focus on are healthcare costs, patient outcomes, and patients' quality of life. This being said, this is recognized as one of the most official translational gaps, since cost effectiveness analyses are still rare to date. But this is likely most often due to the fact that few biomarkers actually have progressed. As we saw, it's a very limited percentage have successfully progressed through the research pipeline to this stage. And finally, bringing this all in all together in our final step in designing and implementing and evaluating related public health interventions based on an evidence-based framework, we try to take all this knowledge acquired about biomarker discovery and innovation and actually implement it at the bedside level and above all at the public health level. And through this rotation and reassessment of the evidence-based public health framework, we can secure that the most effective and accurate biomarkers can be actually translated into our everyday practice. Now, how does this all work? I would just like to focus for the last 5 to 10 minutes of this presentation today on one of the many applications that have adopted today such steps and epidemiological tools for maximizing BM research investment, and focus on one of the case studies, which is that of the CKD273 classifier in relation to chronic kidney disease in diabetic patients. Now, this classifier started from actually a European framework program, the Marie Curie International Training Network Action. The title of the program was Identification of the Molecular Determinants of Established Chronic Kidney Disease. And this program actually began with the unbelievable talent of 10 PhD students from different disciplines, and ranging from proteomics all the way up to systems epidemiology, who through their mentors in more than 10 academic and research institutions from different countries across Europe, strove to actually identify a biomarker, a novel biomarker that could improve the quality of patients' life, and specifically diabetic patients with chronic kidney disease, so as to diminish the severe health and economic burden and provide a better diagnostic and prognostic means of these patients. So therefore, they sought to bring together through this concerted effort coordinated under the Biomedical Research Foundation of the Academy of Athens under the direction of Dr. Vlachou there, to develop these new diagnostic and prognostic biomarkers that could guide both the diagnosis of chronic kidney disease and also the prognosis of patients and guide treatment outcomes. Now, through this process, the 6 steps were actually adopted. And this was actually our test drive of these. And if you like, a proof of concept that these applications of epidemiology can actually work to the benefit of both researchers and patients alike. So for the first step, to identify a clear clinical need or current gap in clinical practice, well, based on the criteria, we do know that according to the big bad wolf paradigm, chronic kidney disease, CKD, is quite big, bad, and dangerous. It inflicts more than 10% of the adult population in high-income countries. It may often progress to end-stage kidney disease, and it usually arises either after diabetic nephropathy or hypertension. And since it's projected that particularly diabetes will affect more than 300 million patients worldwide, the healthcare associated costs are not only enormous to date, as they approximate more than 80 billion US dollars among US Medicare patients alone, but it's projected that this will be an ever more emergent concern for both clinicians and healthcare policymakers alike. So currently, CKD diagnosis is currently based on the detection of urinary albumin excretion, or a reduction in estimated glomerular filtration rate, also known as eGFR. However, despite the absence of detectable UAE or microalbuminuria, CKD can nevertheless progress in a significant proportion of diabetic patients. So the project here came to cover this gap that currently exists, and to provide a more accurate, novel means for the timely detection of CKD and the consequent prevention of disease progression and complications. And ultimately, the aim was to deter or to delay ESKD, the necessity of dialysis, or death. Now, the conceptual approach was based on proteomics, and it's quite simple if you think about it, but at the same time, quite innovative. So using proteomics platforms, CEMS platforms, the concept was that you could apply proteomics at a very early stage of disease, if you like, where there's minor structural organ damage, much earlier than traditional diagnostics come in, which usually can detect or have an accuracy after there is some degree of more advanced organ damage, so as to predict which patients have the disease and actually identify them at a preemptive stage. And therefore, the early diagnosis can guide early treatment and therefore improve patient outcome. To do this, they proceeded with the second step, which is to conduct biomarker discovery and appropriate study design, and using one of the many proteomics platforms available. Here they use the capillary electrophoresis mass spectrometry, CEMS approach. They developed a urinary peptide classifier. So this is a non-invasive peptide classifier, which was identified as CKD273, based on a case control study. So this was the initial study, which compared 230 patients suffering from CKD with 379 healthy individuals. So this was a proof of concept study, opted for a case control strategy with healthy controls. Through this, it was identified that 273 urinary peptides differed significantly between the patient and the control groups, and therefore using support vector machines, these peptides were, if you like, integrated into a single non-invasive classifier. And it was found that its accuracy was actually extremely high, as its area under the curve, the AUC, was 0.92 in discriminating between diabetic nephropathy and atherosclerosis from healthy individuals. Now, after this set, several other studies were conducted to validate these discovery set findings, assessing different disease stages based on GFR level and also CKD. So they ranged from early disease stages all the way to more severe disease stages and even end-stage renal disease. A number of different studies, including case control and longitudinal studies. And overall, when these were all pulled together, it was found that the overall sensitivity was quite high at 86%, and the overall specificity was even higher at 99%. So in sum, these initial findings, and through the validation process, it was shown that the CKD273 could actually accurately detect disease, especially at early disease stages, and could also be used as a predictive marker of CKD progression. Now, although there was this volume of studies, if there isn't a standard approach for assessing the quality of independent investigations finding, you can't really proceed with evidence level grading. So we then proceeded to independently collect and assess these studies, and we selected from what was available at that time, which was prospective cohort studies, a selection of these, which were of the highest methodological quality. And we actually found that following the application of the Oxford EBM criteria, the evidence-based medicine criteria, most of the gradings of the studies, and this is just an excerpt from the total table, was actually at the highest level of evidence. So it was at evidence level 1. And just to make sure that our scoring was right, we actually implemented a second scoring technique, which was called the SWORD score. And that also showed some disparities. But that being said, we found that there was a consistency for most of the study findings. As a second to final step, we conducted a cost-effectiveness analysis to see, well, if this promising biomarker could be actually translated into clinical practice and public health practice. And we conducted this cost-effectiveness analysis, and lo and behold, it was found that although the use of these state-of-the-art platforms, the CKD273 classifier, was more costly, it was also more effective in terms of qualities gained, that is quality of lives gained among patients. And actually that ratio, which we usually express as an ICER, was below the willingness to pay thresholds, which are set by most government standards for adopting such biomarkers into clinical and public health practice. And we actually found that the greatest benefits were among those at highest risk for developing diabetic nephropathy, secondary to cardiovascular disease related complications. So not only was this biomarker panel accurate for use, it was also found to be effective, and in the long term, it was found to be below that threshold that a government would be willing to pay to adopt it. So as the logical next step, it was adopted. It was prototyped. It was taken up by an independent company in Germany and first targeted there. Subsequently, and soon after, the FDA actually picked up on this biomarker, which was for commercial purposes then patented, and then recommended its further use in clinical trials. And following that step, lo and behold, step by step, it was first implemented in randomized trials, then further validated for use as a monitoring biomarker in randomized trials. And as we proceed to go on, since this is still a work in progress, we anticipate that this biomarker will be further translated into a more widespread community practice within Europe. As I mentioned, it has already been adopted in several European countries, beginning from Germany and then spreading to most of the other, at least Northern and Central European countries, and also the US. So we anticipate that this will reach a population level for most of Europe within the next few years. So a summary and future outlook after all of this. Biomarkers are underway and they can be compiled with several different platforms and approaches. But the most forthcoming and interesting milestones to be achieved are that increasingly these biomarkers are taking a step further to not only combine different omics techniques, but also to integrate other lifestyle and other risk factors that can be used. Above all, what I would like and for you to take as a take-home message for today is that no matter which platform is used, a vast array of epidemiological tools can be applied, and a 6-step approach can be used to maximize this research investment, especially if there is an availability of biomarker use. And finally, all these can come together to bridge the divide between bench and bedside research. I would like to acknowledge, since these works are never done by a single group, but are concerted efforts across several academic institutions. And above all, would like to thank you for your attention, and I'm